Thanks, Dr. Hensley, for inviting me. And I know that I am the final barrier between you and dinner. So I really appreciate your staying to hear about the challenges and potentials of this keyboard advancing by itself, of finding the Achilles heel of solid tumors and getting the immune system to recognize them. So I'm going to talk about 4 things today. First, the clinical impact of checkpoint blockade therapies in melanoma and other malignancies, followed by a brief background on drug mechanisms. Then I'll talk about what was until recently my research focus, which were tumor genetics, neoantigens, and checkpoint blockade efficacy in melanoma and lung cancers. And finally, what could be the application of immunogenomic analyses to ovarian cancers, which in this setting I'm talking about high-grade serous ovarian cancer. So today I'll focus on the 2 circled checkpoints, cytotoxic T lymphocyte antigen 4, or CTLA-4, and program death 1, or PD-1, and its ligand PD-L1. As you all know well, in the recent past, outcomes for melanoma patients were abysmal. However, this was a landmark study of checkpoint blockade in melanoma. In this study, CTLA-4 blockade with ipilimumab was given to patients either alone or with a vaccine that didn't actually work, or with the vaccine alone, which is the bottom curve, and showed an improvement in overall survival in those patients who received ipilimumab. To me, a remarkable phenomenon, which is what makes me passionate about this field, is the tail of the curve. These patients who survived 4 or more years despite having metastatic melanoma. In other words, to those few patients who responded, this agent provided durable disease control. We kind of had another leap forward this year in a study led by our own Jed Walchuk and Mike Posto, where we saw the tremendous potential of combining ipilimumab with the PD-1 blocking agent nivolumab in metastatic melanoma. And you can see from the waterfall plot that only 4 patients had disease growth as their best response. The median decrease was 68%. This compares favorably to ipilimumab, which is shown on the right. And these responses were not just deep, they were durable. So the left-hand panel shows with open circles the first evidence of objective response, and the arrows indicate ongoing responses at the time of analysis. The red bars indicate treatment discontinuation, so you can see that despite stopping therapy, many of the patients continued to benefit. The right-hand panel shows the Kaplan-Meier curves for progression-free survival among patients treated with the combination or ipilimumab alone. And the not reached up here indicates that progression-free survival hadn't yet been reached at the time of analysis in the dually treated arm. So you can imagine our excitement to try and figure out how to make this sort of change in outcomes happen to our patients with high-grade serous ovarian cancer. So what are these therapies doing in other cancers? In this slide borrowed from the AACR plenary by Dr. Alley, we see that the PD-1 blocking agent pembrolizumab has shown promising efficacy in diseases that had previously been refractory to therapy in the advanced setting. But where is ovarian cancer on this graph? Well, it didn't make that talk, but 3 studies performed in ovarian cancer and reported last year and this year at ASCO do suggest that these agents may have some efficacy in ovarian cancers. This slide is from the largest study, which was a study of the anti-PD-L1 agent avelumab in ovarian cancers. Although the follow-up was short at the time the study was reported, you do get a sense that there is, again, some durability as you follow the spider plot out to the right. Although the selection criteria between these 3 studies was different, and so it limits comparison, the response rates were in the 10 to 15% range, and disease control was in the 30 to 50% range, so quite promising. And based on these data, several trials have been opened, including here, as well as expanded to include our patients. It's important to note that, though, at the moment, we're still applying melanoma drugs to ovarian cancers and that there may be disease-specific targets, and that's a focus of my ongoing research. As a side note, for the handful of clear cell patients that were treated with these therapies, anecdotally, the response rates were extraordinarily high, which remains to be confirmed in a larger group. Another step that's likely to be important in our disease is combining checkpoint blockade with conventional therapies. A study in renal cell carcinoma hinted at the potential benefit of combining anti-PD-L1 with the anti-angiogenic agent bevacizumab. In this small study of 10 patients with metastatic RCC, only 1 patient treated with this combination had disease progression. And interestingly, if you look at PD-L1 immunohistochemistry conveyed here as well as in the spider plot, you can see that it doesn't seem to really matter, which begs the question of whether combining therapies might be able to overcome potential sources of resistance. This small study also, again, suggested this idea of durability, and a phase 3 trial is currently underway in renal cell based on this. So in a nutshell, these checkpoint blockade therapies seem to allow the immune system to recognize the Achilles heel of the cancer. But how? So that brings me to a background on the drug mechanisms. As you all may already know, CTLA-4 acts as a checkpoint on T cells, shown here in this cartoon. So while this T cell receptor major histocompatibility complex interaction is happening, because of this interaction, the T cell is essentially off. So if you block the blocker with a drug like ipilimumab or tremelimumab, that facilitates the activation of the T cell. A similar principle applies over here with PD-1 and PD-L1, although the drug here is thought to primarily act at the tumor site. My own research focus is trying to figure out what is going on here. What interaction is motivating the T cell to respond only to be blocked by the checkpoint receptor? So we think that the Achilles heel in melanoma and melanoma and lung cancers are neoantigens. A neoantigen is an abnormal peptide that results from a somatic mutation that can be presented to and recognized by a T cell, and that's represented by the red blob. As you can see from the cartoon, if you have an abnormality at the DNA level, this will be transcribed and translated in such a way to have the potential to be recognized as foreign. Bioinformatically, we can virtually translate the region surrounding a mutation to figure out what abnormal proteins could be made. Here is an example of a change from leucine to isoleucine. In this example, the change alerts the T cell that something is amiss. A program called NetMHC is used in conjunction with the patient's own HLA type to figure out which part of this protein, if any, that particular patient might present to a T cell. As someone with a history degree, I'm happy to credit our forerunners who knew all of this long before we had the technology to study it as we are now. Lloyd Old and others all described these examples of the immunogenicity of chemically induced sarcomas, which presumably harbored neoantigens. In fact, Bob Shriver's lab has shown that's exactly what was going on. He showed that this carcinogen-induced sarcoma line produced rejection antigens. In this example, they identified a mutation in spectrum beta 2, which, when transfected into a cell line, caused the tumor to be rejected as compared to the wild type or control. So this brings me to the question of how tumor genetics might influence checkpoint blockade efficacy in melanoma and lung cancers. As it turns out, a similar phenomenon to what was happening in the mice appears to be happening in the patients. A higher number of mutations leads to the formation of neoantigens, which increases the chance of their recognition by T cells. Working with a large team led by Jed Walchuk and Tim Chan, and with bioinformatics performed by Vlad Makarov, shown here, we found that in both melanomas treated with anti-CTLA-4 agents on the left, and in lung cancers treated with anti-PD-1 agents on the right, an elevated mutation burden was associated with durable benefit greater than 6 months. However, there are exceptions. So especially in melanoma, it seems there are these tumors that have a mutation burden below the median of non-responders that nonetheless respond, and conversely, high mutation burden tumors that do not. So it's an imperfect association. However, we hypothesize that one of the reasons these correlate is a question simply of probability, that the more mutations a tumor has, the more likely it is to generate a recognizable neoantigen, i.e. an Achilles heel. In this lung cancer study spearheaded by Matt Hellman, shown here, mutation burden and neoantigen burden, as expected, are interrelated. And in fact, they're inseparable and are both associated with progression-free survival. The same is true of melanomas, which we showed in our work and was recently confirmed by Levi Garraway in a larger data set. So the next question becomes, is this all bioinformatic fancy footwork, or is there something measurable here? Can we see and measure the immune system recognizing these neoantigens? So Ton Schumacher was the first to show this principle in a single patient treated with ipilimumab. And you can see here that that patient's tumor-infiltrating lymphocytes on the left and even peripheral blood measurably recognized a patient's neoantigen. In our study of melanoma patients, we confirmed this. So in this example, autologous peripheral blood mononuclear cells, in other words, the patient's blood, recognizes this predicted neoantigen here as compared to the wild type, and the cells displayed a CD8 positive activated phenotype, meaning having TNF-alpha, CD107, and MIP1 beta. So in summary, these two studies show that T cells can recognize tumor neoantigens in melanoma and lung cancer patients treated with checkpoint blockade therapies. So how does all of this relate, or can it relate, to ovarian cancers? Well, the median mutation burden of an untreated ovarian cancer, meaning the single nucleotide variants, is much lower than the rate in the non-responders in the two studies I mentioned, and yet a few minutes ago I said that the durable disease control rate was 30 to 50%. So what is going on here? One possibility is that the mechanism is entirely different. An additional and not mutually exclusive possibility is that chemotherapy itself may be increasing the mutation and neoantigen loads in advanced disease. So a paper by Patch came out that Doug Levine mentioned earlier today, and we recently reanalyzed a subset of that data, looking at samples where there was a primary and a recurrence with multiple chemo treatments in between. And you can see that in general, but not always, the number of mutations unique to the recurrence went up after multiple treatments. When we look at these in paired fashion, so you see it goes primary recurrence like that, primary recurrence, if we set the threshold for potential response to checkpoint blockade at about 110 mutations, you can see that only 3 primaries go above that threshold. But after exposure to multiple lines of chemo, 9 more tumors sort of go into that potential response group. But are these mutations clonal or subclonal? In other words, is the chemotherapy just creating a big mishmash? Because in data that I won't talk about right now, it seems like a bunch of very infrequent neoantigens probably isn't helpful. Well, it actually seems so far like the chemo selects for a few more dominant subclones, although we can't tell from this bioinformatic data whether these actually generate helpful tumor neoantigens. The other thing that's important to remember is that while chemo is mutagenic, it also, as Dr. O'Carroll was saying, is immunomodulatory. So in this study of doxorubicin by Lawrence Zipvogel's lab, they found that in mice who experienced interferon signaling blockade using interferon receptor antibodies, they continued to grow despite doxorubicin treatment with the red arrows in each group, whereas those who had intact interferon signaling were killed by the drug, as you would expect. Similar concepts have been shown for certain other chemotherapies. So to wrap up, I want to conclude with a case of our own that illustrates how T cells really may have the power to control ovarian cancer. So this is a patient of Dr. Connor and Dr. Zavanovich, who underwent debulking in 2007. She then got IVIP cystaxel. She recurred, unfortunately, and she continued to progress on 7 lines of chemotherapy. However, after the plan was made to transition to best supportive care here, a very strange thing happened, which is that her CA-125 went down and her tumors started to shrink. Ultimately, in 2014, her intra-abdominal disease was resected, and we've begun to analyze this. I'll show you preliminary data now, and the beautiful IF that I'm about to show was done by Yan-Yun Lee in Jed Walczyk's lab. So in this slide of her primary tumor, the blue are tumor nuclei stained with DAPI. The red are nonspecific staining of red blood cells, green. And the red, green, and yellow are supposed to be T cells. Well, there aren't any. But then when we looked at one of the regressing tumors, incredibly, you saw they were just chock full of CD4 and CD8 positive T cells, which are thought to be anti-tumoral. And they're really negligible FOXP3 positive T cells, which is a suppressive type of T cells. In contrast, when you look at one of her progressing tumors, it really looks like the primary. The tumor itself is devoid of T cells. In fact, it looks kind of like the T cells ran up to the tumor and then stopped in their tracks. This phenomenon has been described and characterized really beautifully in pancreatic cancer and is thought to be one of the reasons for resistance to checkpoint blockade in that disease. However, no story in biology is quite that simple. So if you look at two other regressing lesions, they're both still full of T cells, but this one is only CD4 positive, or almost exclusively, for reasons we don't yet understand. And this lesion, which was a mix of progressing and regressing segments, but Yanyan assures me this shot is from a progressing portion, was full of T cells, but these T cells are obviously not doing what these ones and these ones are doing. So the next slide is hot off the presses. I literally got these data yesterday. We've started to analyze the genetics associated with the immunohistochemical slides I just showed you. So if you compare the mutations in the primary, the growing, and the shrinking lesions, the shrinking have distinctly more mutations. There are only 35 shared between all three. And interestingly, there are 25 shared between the growing and shrinking, suggesting they were at some point on the same trajectory and then divided. If we look at this psychedelic Venn diagram on the right, where it's boiled down into these shrinking lesions and these growing lesions and the primary, again, you see fairly small amount of overlap. And in fact, these tumors are really quite distinct. So although this is a very unusual case, and where Doug Levine is doing an incredible job of helping me expand this into a real case study of over 20 cases, you can see that the chemo really seems to have driven the tumors in various directions, or maybe that's what they would have done anyway, even without the chemotherapy exposure. We don't actually have the neoantigen calls on those samples yet. So in conclusion, today I've focused on my area of specialty, which is what's happening right here when the T cell sees a neoantigen. But you can see that the tumor microenvironment provides a rich and complex set of potential targets, and our own Dimitri Zamarin, who I'm going to embarrass right here, is doing some really fascinating work using oncolytic viruses to induce inflammation. So in conclusion, in tumors from patients with advanced melanoma and lung cancers, CTLA-4 and PD-1 response seems to correlate with elevated mutational load. In these diseases, we think this is from an anti-neoantigen T cell response. Ovarian cancers have a substantially lower mutational load, although chemotherapy may increase this, as this one case might suggest. And ongoing studies, again, tremendously aided by Doug Levine, are helping find a disease-specific Achilles heel in ovarian cancers. Preliminary clinical data gives us reason to hope that checkpoint blockade can work. And this ongoing study is going to integrate protein-level data along with T-cell receptor and somatic sequencing to try and see if we can figure out the optimal immune microenvironment to target ovarian cancers. The melanoma and lung cancers, although I just showed a couple slides, involved literally an army across subspecialties to execute, and I'm happy that your own disease management team, which I've been privileged to join recently, has really the same capacity. This also takes a lot of bioinformatics. This whole team works with me at Mount Sinai and CRUK. And then last but not least, this lady, to a junior and female physician scientist, having a role model and mentor like her is an extraordinary privilege, and I know that not just for me, but for others at this institution and on the national and international stage, she really gives us a role of how one should conduct oneself, both in research with colleagues and with patients. Thank you.
That couldn't be a more wonderful sentiment to end on. Thank you so much, Alex. I want to say thank you to everyone for coming today. Just a couple of announcements. Dr. Agajanian will actually give the keynote address at Grand Rounds tomorrow morning, 8 o'clock, and that will be delivered in this auditorium, so not the usual Zuckerman, but here for Grand Rounds to hear Carol. And also tomorrow is a day of pathology talks, which I want to highlight that Rob will be speaking at Rob Sossel will be speaking at 9:35, but their keynote speaker is at 11 o'clock in the morning, and it's Dr. Robert Henry Young. He goes by Robin Young, and he is a great sarcoma pathologist, and that talk is at 11, so if you have time to carve out tomorrow to come hear him, that would be great. And thank you again for coming and for staying all day and for your enthusiasm as an audience. It's really been a pleasure to put this together. Thanks.